So let's talk about the coronavirus now. Is that fear justified?
No, I'm going to speak directly to the American people and to the people of the world that I have some very good and optimistic news for you, which is the following: that there is an effective, cost effective, safe oral approach that, if done properly, which I can explain to you what that means, converts COVID 19 to a similar type of infection as influenza. In other words, it's not a good infection, but it's manageable, it's treatable. We don't need to close down the economy. We don't need to have unnecessary death. So, with your permission, I would like to explain to you what I've discovered. I'm a primary care doctor for a community of 35,000 people in upstate New York, and they live within a square mile. And when the COVID 19 virus hit that community, it hit it with a severe number of patients, almost everyone getting sick at the same time. So my office was inundated by, instead of seeing 40 patients a day, we were seeing 250 patients a day. And it became very obvious to me that the world didn't know what they were doing. For example, the whole emphasis on treatment of COVID 19 was to build more respirators. Essentially, what we were telling patients is they would come to the doctor's office. We would say, okay, you have the coronavirus probably. Go home, take some Tylenol, drink fluids, and when you get into respiratory distress, go to the hospital. We'll intubate you, and then there's a 90% chance you're going to die. And so that didn't make sense to me. So nothing was being thought of or suggested to treat patients in the outpatient setting to mitigate the course of the disease, to improve the outcomes. I have a solution for the respirator crisis. Don't get on the respirator. So what I started to do, I started to do research, and I looked around the world, what was being done. I looked into what South Korea did, which was use hydroxychloroquine and zinc. I looked into France, Marseille, France. Dr. Didier Roule was doing research with hydroxychloroquine and azithromycin. And what I decided to do was combine the different regimens, different approaches from those countries, and I came up with a three-drug approach. I modified the dosing to reflect less acutely ill patients, and I started intervening with my patients immediately upon presentation. In other words, I didn't wait for the results of the testing. If the patient seemed to have COVID 19, I would do the testing, but I would initiate treatment immediately and not wait because the testing took 3 days to get back. So I'll give you an analogy. Imagine you have a fire in your kitchen and you call the fire department and they say to you, I'm going to come in 3 days. That's exactly what we were doing to patients. Did it make sense? Nowhere else in medicine do we ever, we're not going to treat your cancer until it's metastatic. Or we're not going to treat your infection in your toe until you're half dead and septic. Except when it came to COVID 19, that's exactly what we were doing. Did it make sense? So I started intervening, and I slowly developed what is now known actually as the Zelenko protocol, which is the following.
But let's talk about it. Yes.
So I saw 2,200 patients in my team with COVID 19 in the outpatient setting over 4 months. 2,200 patients, probably more than anyone else in the country, if not the world. And my outcomes are the following, and it's all documented in a paper that I published, that we had two patients die out of 2,200. One of those patients had advanced leukemia, and the other one was elderly, and when he presented was already very, very sick. And I had four patients end up on a respirator. Now, let me give you the approach. I didn't treat everyone. I risk stratified patients. In other words, patients that I considered high risk, which I define as if you go to the hospital and you see who's dying, which patients are dying, which patients on the respirator, you'll find out very quickly it's patients over the age of 60 or patients younger, but they have medical problems, diabetes, high blood pressure, heart disease, and so on, immunosuppression, like, cancer. So these are the patients that were getting complications from COVID 19, but everyone else was recovering on their own. So out of those 2,200 patients, I actually only treated, quote unquote, with medication, 800 of them. In other words, the rest, which I considered low risk, were given supportive care, meaning go home, have some Tylenol, drink some fluids, and if something doesn't, if things don't go well, give me a call, follow up. And out of those patients, out of the remainder of, was it 1,400 patients, 100% of them survived with no hospitalizations. Now, the 800 high-risk patients over the age of 60 or under the age of 60 with medical problems, I treated with medication within the first 5 days of the onset of symptoms. And that's extremely important, and I'll explain to you why. If you look at the viral load dynamics, in other words, how much virus is in the patient, the first 5 days at the onset of symptoms, it's essentially flat. It doesn't really change. But around day 6, it explodes like a wildfire. Now think about it. Most people don't go to the doctor right away. Someone gets sick, they wait 2 days usually. Then they realize, wow, it's not getting better. So they call the doctor, day 3. Then you don't get the appointment usually the same day. So you come to the doctor between day 4 and 5. So I was seeing patients on average between day 4 and 5 of COVID-19. And the testing took 3 days to get back. That would bring them into day 8. By then, they're really sick. So what I decided to do is if I suspected that the patient had COVID-19, I would treat them on clinical grounds. I wouldn't wait for the results of a test to make a decision. In other words, if I thought about it, I treated. And so that's the second part. In other words, the risk stratify the patients. In other words, cherry pick the high-risk patients. Initiate treatment as soon as possible. And then I used a 3-drug regimen. Here it is: zinc, hydroxychloroquine, and azithromycin. And let me explain to you how it works. It's very important. You have an intelligent audience. So the virus is inside the cell. Viruses, by definition, need to hijack the cell's machinery to reproduce. So a virus gets inside the human cell. And there's an enzyme in the cell which helps the virus replicate. It's called RNA-dependent RNA polymerase, or replicase. That's important because it turns out that zinc kills that enzyme. In other words, it inhibits viral replication. But there's a big problem with zinc. Zinc does not get into the cell because, if you know biochemistry, zinc is dissolved in solution in the plasma. It's a positive ion, and the cell membrane is lipophilic, which basically means it's like cholesterol. In other words, oil and water. So they don't mix. So the zinc cannot get into the cell. So that doesn't help you. So what does hydroxychloroquine do? All it does in this particular instance is open up, it's called a zinc ionophore. It opens up a channel that allows for the zinc to go from outside the cell to inside the cell. Very simple, very elegant. That's all it does. It's a gun and a bullet analogy. In other words, a gun without a bullet and a bullet without a gun are completely useless. It's the combination, the synergy of the two that makes it effective. So zinc needs to get to the place where the virus is. The hydroxychloroquine delivers the zinc into the cell. Now, the azithromycin, or I sometimes use doxycycline, which is an antibiotic, what they most likely do is prevent secondary bacterial pneumonias, which are very common with people with COVID-19. So in other words, here's the concept. Get the virus killer inside the cell and protect the patient from developing complications by giving them antibiotics. And that's it. So listen, this is what happened. I had, out of those 800 high-risk patients, you would have expected a 10% mortality rate. That's 80 dead people. I had 2 dead people. You would have expected a multiple of that on ventilators, at least 100. I had 4. So I realized, I'll give you, in other words, I wasn't doing research. I was looking for a solution to keep people alive. And I'll give you an analogy. I felt like a frontline soldier who stumbled across some very important intelligence. And I needed to communicate this intelligence to the 5-star general in order that he has the information to win the war. So I realized the implication of what I found. So I don't have connections. So I decided to make a YouTube video, and I didn't even know how to do that. I had to use my 17-year-old son he's a millennial, to actually help me. And I made a video and I appealed to the President of the United States. And I said, Mr. President, I have something very important to tell you, and please contact me. The next day, Mark Meadows, the president, at that time he was the incoming chief of staff, calls me on my cell phone. And he says, I saw your video, how can I help you? So I told him what I was seeing, and he said he's very interested, and just to keep him updated. And this was early in the process, so I didn't have that many patients to report. And then subsequently, Rudy Giuliani reached out to me, and I ended up doing a few podcasts with him. And the first podcast was seen by, I think, 800,000 people. And since then, um, I'm advising currently 7 countries on their COVID-19 response. For example, the entire country of Honduras is following the Zelenko protocol. Bolsonaro, the president of Brazil, is a big fan of my social media, and he just recently got COVID-19. He took the protocol, and he's doing great. And large sections of Brazil are now coming on board.
President Bolsonaro took the Zelenko protocol when he got COVID-19.
Correct.
So let's just go back for a second. I want to get, because the politics is going to muddy the waters just a little bit, because hydroxychloroquine has become so deeply politicized for reasons that I can't quite fathom.
Well, I can clarify that.
Well, you and I have talked about it, but let's not jump the gun, because people have not been privy to our conversations. So first of all, what you've said until now makes a lot of sense to me, because I've seen people get very sick with COVID-19, and I've seen that they have become unnecessarily sick, meaning I'm not a doctor, and I know my limitations. I'm not a doctor. But I also know that when people that I knew first thought they had symptoms and went to a primary care physician or an emergency room, and even if they were told by a doctor, you know what, I think that you have COVID-19, here, let's do a test. And now, of course, the test, you don't get an answer for 4 or 5 days. And I've seen that what you're saying is correct. What a tragedy. They're getting unnecessarily sick because they're not being given anything. Without the Zelenko protocol, if someone goes to an emergency room and they say, look, we think you have COVID-19, here's it, take a test, you take a test. Now we have to wait 3 or 4 days to see if you're positive or negative. What do they give them then? Nothing?
Nothing.
Nothing. Zero. Nothing.
Right.
So we're just creating a situation where high-risk patients can get extremely sick, God forbid, and be forced to fight for their lives, which is preventable. That's what you're saying, right? That's a really serious thing.
My data shows the following. If you follow my protocol, my data showed an 84% reduction in hospitalization. Let me explain to you what that means. Out of 100,000 admissions in the hospital, we could have prevented 84,000 of them with a drug, by the way, which is safe and costs $20 and is oral by mouth. Do you understand the implications of what I'm saying to you? Let me clarify it if you don't.
I understand the implications, because
scale
this is directly impacting.
If you scale this approach, no, here's the implications though. If you scale this approach nationally or globally, that's the end of the pandemic.